So welcome back. Our next talk is Associate Professor Rickard Brånemark at the University of Gothenburg at the MIT as well. So he's going to be talking about osseointegration and the work that has happened in Sweden and around the world on this revolutionary technology, we'll say. Please.
I would try to cover a little bit more than 60 years of work in 15 minutes, so here we go. So if you want to develop something that is new and a bit provocative, you have to be a bit stubborn. So what is this? This is an introduction. You will talk about it, Oscar, or? Okay, so if you come to the dinner, we will tell you what this is. So this is how the field of osseointegration started. So it was an attempt actually to study microcirculation in bone tissue. And this special implant was developed. And the material chosen was titanium. And here you see the researcher, and this is P.I. Brånemark. My father is looking into microcirculation in bone tissue for the first time being able to really study that. But he was also interested in microcirculation in other tissues. So this is some of his PhD students at the Department of Anatomy in the early 60s created this skin tube, put a small implant through it, and can study microcirculation in humans for the first time. And here you see red blood cells in a capillary in a human. And he went on to study bone healing. He understood that the titanium implant that was so fixed to the bone tissue might be able to be used for reconstructive surgery. And he tested it in some beagle dogs. And you see this nice James Bond dog. And then this ended up into dental implants. But if we go back to titanium, so what do you know about titanium? It was actually Gregor that found titanium for the first time in Tregonwell Mill. And then there was a guy called Klaproth that called it titanic earth. But who was it really that first purified titanium? Jöns Jakob Berzelius, a famous Swedish chemist in 1815 or 1825. So that's how recent titanium has been used. So, and what is this? This is where Tregonwell Mill was, Cornwall. And who is that to the right here? That is P.I. Brånemark. And so he is the one that coined the word osseointegration and used that to treat amputees, dental amputees. So here, for example, is a slide that I got from him. 30 years follow-up with the small titanium implants. Could work for long. And this is what it looks like. A prosthesis. This is his famous 10-year book, and where they first coined the word osseointegration, 1977. So what is osseointegration? Well, today we still don't really know what it is, but one thing that we can observe is that the bone will grow directly onto the titanium, and there is no fibrous tissue in the interface, so there is really no inflammatory reaction in the long-term perspective. Because in the short term, there is actually a rapid inflammatory reaction. And we did tons of research, and I just want to take this one. This is from Bustin et al. 1989. And he could show that under certain circumstances, the titanium oxide could trigger a downregulation of inflammatory cells. So there is something happening. So the surface is not completely inert. That was believed from the beginning. There's something happening with the biology. So here are some other applications. These are extraoral applications started in 1977. And the basis here is, again, difficult to really attach a prosthesis. This is an eye prosthesis. These are some rare patients treated by my father. This is, I think, a patient treated in Brazil with a big mid-face tumor, and of course a devastating result, but with a great team with dental technicians and surgeons, a new face. And with engineers like Bo Håkansson, you can create bone-anchored hearing implants, so you can hear with a titanium implant. So for many years, the focus was in dentistry and ENT applications. But I've been mostly working with orthopedic osseointegration. And one of my colleagues you see to the far right here, and that is Örjan Berlin. And in the middle, you see the two Mayo brothers when we did a presentation at the Mayo Clinic maybe 2 years ago now. So, orthopedic osseointegration, why? The socket is a great solution, but it's actually a bad solution. From a biomechanical perspective, we have the skeleton for great load transfer, and with the socket you have to route this through the soft tissues, and then you get all the problems we have with the sockets: pain, sores, sweating, poor retention, etc. And there are studies showing this from the San Francisco Bay Area, where I live these days, 1983, and somewhat more recent. Now you see this 2001, so we've been around for long, and this is a part of Kerstin Hagberg's PhD thesis, showing that the socket is creating a lot of problems for the amputees. And this has been sort of known for long, and I tried to do something in the 60s in the LA area, but it failed. So it was believed that you cannot really have a bone-anchored amputation prosthesis. But in 1990, the first Osseointegrated amputation prosthesis was tried in a young female here in Gothenburg by my father and Professor Björn Rydevik. And in principle, the Osseointegrated amputation prosthesis is just bypassing all soft tissues and the socket completely. And the design of the OPRA implant system that was set in 1998 already included a plug that has now become famous because it can be upgraded to the e-OPRA central screw and having all these leads coming through. So that means that patients already treated with this system can be upgraded. A key here is not only the bone anchorage, but the skin interface. And maybe you say, okay, this looks okay, what is this? Well, it took about 10 years to develop the surgical protocol to fix this on a thigh. Another lesson we learned was that surgery is great, but rehabilitation is also utterly important. So again, together with Kerstin Hagberg, we defined rehabilitation protocol that tremendously increased the results. We had to retrain the muscles in a special way. And bone tissue, which is a fantastic tissue, is one of the few tissues that can heal without a scar. It's fairly sophisticated, and you need to take care of that. If you don't load your skeleton, that's not good. So you should load your skeleton, and when you load your skeleton, you deform the skeleton, and then you induce a fluid flow in the canaliculi, and it's the shear stress of the fluid flow in the canaliculi that Frangos in San Diego showed to stimulate bone formation. I have had a cup of coffee with Frangos. Happy for that. So, is this a treatment without complication? No, for sure there are tons of different complications. Like with any surgical procedure, we can have skin infection, deep infections, skeletal fracture, implant fractures, and really bent pieces. So I took this picture to this lecture to show you. So what is great with this picture? How the heck can you bend something like that without fracturing the bone? Because when you load the bone, it becomes stronger and stronger. You just have to treat it nice in the right way. So I moved to San Francisco when this device got the first clearance by FDA. And here is actually a picture from the first surgery done at UCSF. And now there are a number of different centers, I think especially in the US, trying to catch up with the technology. And Jamie Shaw's already talked about their early experience at Johns Hopkins, and we're working with Department of Defense, etc. So that's a very intriguing and challenging opportunity for us. And of course, you cannot only use it for legs, you can use it for thumbs. Below elbow amputations, short transhumer amputations where it's absolutely impossible to fit an ordinary socket prosthesis. You can do wonders with these short stumps. But you have to bring the prosthesis to be alive from a brain perspective. And how can you do that? Well, I guess maybe you've seen these videos already. So this is just a picture illustrating Magnus, the first patient in the world to get this system, 29th of January 2013. I did this surgery together with Oscar, the next speaker. Will you talk about that? No, okay. And there are a lot of things going on, and you already heard about some of the stuff. So top left you see Hugh Herr, head of the biomechatronics group, and in the middle you have Jonathan Forsberg, and then you have left middle you have Todd Kuiken, and in the middle it's the sort of upgradability of the OPRA implant system that is helping a lot of information transfer from the outside to the inside and from the inside to the outside. So if you can transfer a lot of information, you still need to have something that can be useful. And that's something I think we see that with the technologies we're now developing more from a surgical perspective, we need to have better prosthetic devices. And maybe an institution that can help to do that will be MIT. I know that since I worked there myself. And so, and Shreya knows that too. Okay? Mm-hmm. And I know you talked about the agonist-antagonist systems. And so conceptually, what is this really? It's a way of interacting with the brain without needing to decode the brain language, because it's so difficult. It's not as advanced, but it might be useful enough for the patient, and that's what we're trying to explore now. What is it really that is important for the patient to be able to do? Is it to be able to play the piano? Well, you know, I can't play the piano, so for me that's not important. I think it's the basic robust features of prosthetic devices that we need to provide first, and it should be easy to interact with them, so you don't need to use a lot of mental power. So the small titanium screw developed in the early 1960s went into dental implants, and then into walking. We started to see things are happening with body image, perception, etc. You can start with the feedback from the osteoperception. You can utilize your prosthesis for more advanced activities. And now we're starting to more actively talk to and with the brain, so that the prosthesis can be perceived as not the prosthesis, but a part of your own body. But we need to continue to develop ways of interacting with the brain without directly needing to decode the brain signal. And it has to be natural, so with little mental effort. There are a lot of fantastic things we can do together in the future. Thank you.
We have one question.
And the question is, does the skin interface need smooth titanium or porous titanium?
So the skin interface does not need titanium. So the way we do it is that we anchor the skin to biology, directly to bare bone. All others are trying to anchor the skin to smooth or porous titanium, and that, if you look into the science, must fail.
Thank you. That was a question of from the online audience, by the way, wasn't it? It wasn't my student fault. Thank you, Rickard.